our YouTube channel as well as uploaded to the NLADA website. So if you have to bow out at any time for this webinar, you can view it later or send a link to other interested people. So thank you all for joining, especially to our panelists, Joshua Crabtree, James Conway, and Brian Dufresne. This is the final part of the Addressing the Opioid Crisis series. We have two upcoming series, one in 2020, or two in 2020, one on victims and one on reentry. You can access all of these webinars in this series as well as our previous series on veterans at our website, nlada.org/webinars. Can we just make sure that all of the panelists have muted their microphones? Okay, so today's presenters, my name is Casey Chiapetta. I work with NLADA on the Civil Legal Services team. We also have Joshua from Legal Aid of the Bluegrass, Brian, also from Kentucky, and James Conway from Washoe Legal Services. So we're going to start out this webinar with a quick introduction on NLADA resources and some of the things that we've covered in previous webinars, a discussion on partnership and delivery model, questions to guide your planning, and different types of partnerships outside of working with children and medical legal partnerships. Then we will hear from two of our civil members, Legal Aid of the Bluegrass and Washoe Legal Services, and then we will have a facilitated Q&A at the end. Throughout the webinar, if you have questions, go ahead and send those on over. You can either start a private chat with NLADA by clicking on the chat button on the bottom of your screen, or you can send in Q&A through the Q&A chat box on the bottom right-hand side of your screen. You can send these in throughout. If we get a bunch of questions after one of our presenters presents, we will have time for that, and then we also have dedicated time at the end. So like I said earlier, this is a three-part series. In our first webinar, we covered research and funding. This webinar was a really good primer on all things opioids, from understanding how legal aid can help partner in the crisis to how it can fund your work. A key to accessing funding around opioids is identifying how you're already doing this work to help make your case. We covered intersections between opioid or substance abuse and legal issues related to employment, housing, family, and health. All of the links you can access at the end of the webinar, and then we also have the slides already uploaded to the NLADA webinar page if you want to go through and click on them that way. So if you're interested in finding research, we have a few different resources for you. So we have a fact sheet on how civil legal aid can help partner with other organizations to help those affected by the opioid crisis. We also, in the same fact sheet, profile 4 different organizations that have used DOJ OVC money to support these partnerships and this work. One of those profiled is Legal Aid of the Bluegrass, which you will hear in a bit. We also have legalaidresearch.org. So this is our database of all research related to legal aid. We sort it by topic, area, and issue. And then I also want to put in a plug for the Justice and Government Project Toolkit. These are curated research briefs on how legal aid helps various groups of individuals. We also have, alongside the Justice and Government Project, a new curated research newsletter. It's called Just Research. You can access past issues at our site, Legal Aid Resources, and sign up at the bottom. We send a monthly email with the hottest new research topics, legislation and action, tips, resources, points for data, and more. I'm going to quickly highlight a few direct discretionary federal grants. So these are the ones that you apply to the federal agency. You don't go through an intermediary like a state or grant administrator. I'm going to point out 2 of them. So the second one, the DOJ OVC one, This helped fund Kentucky Kids Rise, which is one of the projects that we're going to be hearing about today. And I also want to point out the last one, the Opioid Family Support Program forecast. So some government agencies pending budgetary approval and appropriations will put out grants forecasts. So these are grants that haven't been announced yet, but are forecasted opportunities that will likely be announced in the future. This is one from HHS HRSA, which in the past has been an agency that has funded legal aid and their work around opioids. It was supposed to be officially announced on November 4th, but it hasn't yet been. So if you're thinking about work and how to fund your work, this is one to maybe consider. You can find all of these on legalaidresources.org, which is a resource I will speak about shortly. These are some other federal funding opportunities that you can also use to fund your work. The first grant, Substance Abuse Prevention and Treatment Block Grant, has express language around medical legal partnerships, so that's an opportunity for you. And then I also wanted to point out the state opioid response grants. So far, we know of one legal aid organization that has been successfully funded with this, and that is Vermont Legal Aid, and they are going to be running 3 medical legal partnerships for those in opioid recovery. So you can read about grant forecasts and how to plan for grants that are not yet open at either of those links, and you can access summaries of all of these different federal funding opportunities on legalaidresources.org. We will also be soon announcing in a much larger announcement a shared password protected Dropbox with for civil members who want to share successful grant applications, MOUs, and best practices. So if you have been successful in applying for any of these grants or any other grant like legal assistance for victims, justice for families, and so forth, you can go ahead and contact us and we can upload it to the Dropbox. We're expecting to launch this in early 2020. And then the second part of the opioid webinar series is collecting and using data. So looking at how you can use the existing outcomes that you're tracking or better track your outcomes data to make your case to funders and community partners. So with that, I'm going to begin talking about questions that you should be considering or helping, or that can help you take stock of what the landscape is in your local community or state. So asking these questions can help you begin to map out what work needs to be done in terms of educating partners, for example, policymakers, grant administrators, schools, and other service providers. Taking stock of what's in your area can also help you figure out ways to supplement and not supplant already existing service providers, helping you gain goodwill within the community in a space that you're either trying to break into or expanding your service in. Questions to think about as you're starting to plan for these, and these questions have come with other conversations from legal aid organizations such as Vermont Legal Aid or Legal Aid of West Virginia that have pretty robust programs and projects around opioids. So how can you retool existing programs and partnerships to meet evolving needs? Where might this new project fit and allow you to keep doing the work you're already doing, but find ways to effectively do new work? And then also, as you're building these relationships and partnerships, thinking about how to manage someone or manage staff attorneys with multiple supervisors who might be splitting time among projects, and making sure that you have things put in place to keep these running as smoothly as possible. So one delivery model to help those with opioid use or substance use disorder is a medical legal partnership, or an MLP. So MLPs, and we'll hear from our partner in Nevada soon about how MLPs combine health and legal services at a single site of care in a multidisciplinary team that addresses the social determinants of health. You can read 4 profiles of medical legal partnerships, including one that we're going to be hearing about soon in a resource from the National Center for Medical Legal Partnership. National Center for Medical Legal Partnership is one of our partnering organizations located within the School of Public Health at George Washington University. And we also recently had a webinar on things to consider when launching, sustaining, and expanding MLPs with health centers. You can access that webinar on our general webinar webpage, and they also have many resources available to you. And I see that we have a question about whether the slides will be available. Yes, the slides are already available on the NLADA webinar page. You can access that by going to nlada.org/webinars. All right, so another model is models that focus on children. So both actually all of these projects have been supported by the DOJ OBC grant to serve children affected by the opioid crisis, which I highlighted earlier. And you can read more about this grant both at the opioid fact sheet that was linked to an earlier slide, or by going and visiting the page on legalaidresources.org. I'm going to highlight the Lawyer in the School project from Legal Aid of West Virginia, which we spoke about in different contexts in the previous webinar. Elizabeth from West Virginia spoke about how they used data and outcomes data to understand and help them fund a project for a large unmet need, which was for kinship caregivers. This grew out of an LSE pro bono grant and has since been funded by DOJ OBC. Over 70 attorneys have assisted with this program, and then many of the attorneys in Lawyer in the School also volunteer with the schools and other programs. Another option is for a delivery is working with the courts. So you can launch pro bono partnerships, work with courts and bar associations to provide legal help. I wanted to highlight two of these different programs, the Texas Can Care Project and the work that Legal Aid Society of Greater Cincinnati is doing. So the Texas Can Care Project provides access to free legal counseling over questions and issues that arise when caring for a relative. They have online free resources such as information about rights and responsibilities and legal tools and advice to help them navigate the healthcare, human services, and school systems. And then in Ohio, the clinic provides information similarly to the Texas Can Care Project to family members like grandparents wanting to get custody of their grandchildren. And for these people, they may speak to a lawyer who can help them get power of attorney and not custody. Both of the links I wanted to point out are to local news stories about their projects, which is also a plug for storytelling and getting your work out there. If you're interested in learning more about storytelling, you can check out Voices for Civil Justice, which has launched a new All Rise project with a toolkit and resources for legal aid organizations wanting to share more about their work. So with that brief introduction on partnership models and service delivery, I'm going to hand the presenting power on over to Joshua and Brian, who work on the Kentucky Kids Rise project.
Hi, Casey. Good afternoon, everyone. This is Joshua Crabtree with Legal Aid of the Bluegrass. Our Kentucky Kids Rise project, and the RISE stands for Reducing Impediments to Stable Education, was really resulted out of just talking with our advocates and our attorneys on staff, and just really what most of you probably have experienced or are seeing is that a very high proportion of our clients and the issues that they were experiencing had some connection to opioids or other drug related issues. And thinking that we really needed to do something more in that area, we created this project. Fortunately, I saw this on the West Virginia slide as well. We are not limited to just opioids in this project, but any drug-related issues that are impacting children or they're victims of crime are clients that we can assist. Our approach is similar. We recognize that we needed a multidisciplinary approach to this issue, and speaking with our attorneys and clients really identified that we needed to add a social worker into that project along with a lot of other providers. But the purpose of our Kids Rise project is to provide trauma-informed legal services for children and really focused on the area of stabilization for the non-parent caregivers or the non-drug-using parent who has had negative or adverse experiences because of that, whether it was financial, legal, and educational impacts. Their families were experiencing these things. So how can we best try to give an immediate response and address something quickly? And what we had determined was that for so many of our clients and these families, in particular in our rural communities, schools were really the hub where people connected, more so than for us, hospitals that were more regional and not in the local communities, and some of these were some of our very rural communities. We identified that schools were really the places where community happened. And the school secretary often knows what so many families are going through. Really, how do we connect at that level with families to find out how we can do some interventions quickly to stabilize housing, get children enrolled in school. That was really the idea behind our Kids Rise project. Our team for Kids Rise is we have a dedicated team of 2 attorneys, along with Brian, who is the director of the project for us, and we also added a social worker for that. So we have 2 attorneys and a full-time social worker that are dedicated to the Kids Rise project, and they provide both the legal representation and the case management for these families. And again, they utilize trauma-informed treatment, a team approach to work with families to remove those barriers, and then once the legal issue is addressed, if there's still kind of a case plan, for lack of better words, the social worker is managing that and then going back and forth with the attorney. Brian, can you share more about the types of cases that we're handling and how we kind of arrived at those?
Yeah, and to kind of piggyback off of some of what Josh said as well, I think it was very fortunate that when we started providing services to these families affected by drug and alcohol abuse, that we did include a social worker / case manager in the mix. For our program, our social worker's name is Sarah Lowe. She's a former Child Protective Services caseworker. She's got a lot of great experience in terms of navigating the juvenile justice system, as well as navigating the dependency, neglect, and abuse arena as well. And really, I think the thought behind that is basically is that, I think when you work in legal services for quite some time, what you start to notice is that certain folks come in and you kind of, you sort of put out that main fire, but then all of a sudden, a couple months later, there's another fire that sort of erupts and you're right back at it again. And then we tend to see, I think, from time to time, folks who are frequent flyers. And when you look at those cases, I think in a lot of those cases, it's not necessarily, those folks aren't coming back because of the, in any way, our ineffectiveness in regards to providing legal representation or legal advice to them. There's some kind of underlying sort of case management, life management issue that may be going on that can only be addressed by sort of accessing those supportive services in the community and those community resources. And I think that the addition of a social worker to the program, ideally for us, is going to allow us to sort of hopefully, make more permanent the gains that we're able to get for them through our legal interventions. So in providing assistance to these clients, essentially, we will provide assistance in a wide range of different areas that we typically go into in the legal services sphere. We'll help these clients access subsidized housing, gain custody of children. We'll help with some educational advocacy. If an individual is there to potentially, and they're losing their home, whether that be rented or purchased, we'll do some eviction foreclosure defense work with them. We'll work with the Department of Community-Based Services here to potentially sign them up for financial assistance for child care if that's an issue for them. We'll take a look at different visitation and rights for grandparents, potential custody rights for grandparents. We'll also take a look at different access issues. What we see is, in a lot of cases, is that we get aunts, uncles, grandparents who, due to a natural parent's drug or alcohol abuse, the child will essentially be dumped on their doorstep, and they hit this point where they're like, oh my gosh, what's the next step? So what we want to do is try to stabilize, after that event happens, stabilize their situation as much as we can by kind of helping them navigate, how do I get the child enrolled in school? How do I pick the right doctor for my child, for my grandchild or my nephew or niece? How do I get them in and sort of consent to treatment for that child as well? We'll advise them and offer some brief services in regards to guardianship proceedings. We'll screen them for the full variety of public benefits and health insurance options that might be available to them. And kind of as I discussed, we'll assist with school enrollment as well. We'll also take a look at different issues which may arise in regards to the caregiver Social Security disability case, or if there is a presumed disability on the part of the child, we'll also kind of take a look at that as well. And once again, visitation rights in many cases for grandparents, aunts, uncles, and things like that. So that's essentially what we'll do. And I think in a little bit we'll go ahead and talk about maybe some new practice areas that we found throughout the first part of the project as well.
Another key component to this project, and thank you, Brian, it was partnerships. Any project like this, or I think any thing you might be considering in relation to addressing this was a huge community crisis in our counties, requires having a lot of other people on board with you. And so public schools have been a partner for us. We don't, as an organization, typically handle education law cases, so that was an easy way for us. We didn't have many obstacles to get involved with schools in that way that some other programs may experience if you're representing kids in school. But mental health providers, domestic violence shelters, hospitals, those have been huge partners from us. Everything from attending the back-to-school Ready Fest that they might have to participating in a more formal way with interagency council meetings, being part of their Champions Against Drugs meetings. We have a wide range of things, attending block parties for families. They have a lot. We just try to do all kinds of activities that really had a presence and a place that were showing the community and the schools were there, and if they were experiencing these issues, to connect with us. The domestic violence shelters put on trainings for staff about legal issues that low-income people were facing because of the opioid crisis. So we were able to do some trainings with there, and then trainings with the mental health providers in our community as well. So all of those ranging from general topics that low-income families are facing to specific ones on housing for low-income individuals or housing insecurity. Those have all been opportunities for us to loop in with this project. Other partnerships, again, with local government and law enforcement. We have some offices where we set up a direct referral with the local county attorney's office, which would be the prosecutor in our jurisdiction. We've been part of community harm reduction task forces, which are really addressing on the ground conditions regarding drug abuse. Being part of other interagency meetings or the Safety Net Alliance. There's a lot of groups that we have connected with, and just really going from everything from just making us known and there as a resource to really having a more substantial role. For example, we are working with and we partnered with one of the largest urban area in our service area, Lexington, Kentucky, with the designated team leader for the mayor's office on opioid issues. Brian, any other partners you would highlight?
I think that's pretty good. I mean, I think what we've done is to kind of take a look at and try to engage with, we have your general community support groups. One of the big sets of groups that we've really looked out to reach out to are our grandparent support groups, kinship care support groups, relative caregiver support groups. That's a really huge need in the state of Kentucky. Nationally, it's right around 4.5% of children nationally are cared for by a non-biological parent caregiver. In Kentucky, that rate is closer to 10%. In some of our hardest hit counties, that's 20, 30, 40% in some cases. So that's really one of the big groups that we've tried to target, but we've also tried to build strong relationships with mental health providers, law enforcement, and then also, of course, with school personnel as well, because in a lot of cases, those are really the folks who tend to know how conditions on the ground are going and sort of what specific crises that community is facing.
And one area that may, traditionally legal aid programs may have concerns about providing representation in, and that we had to kind of rethink our existing model or philosophies, has been providing representation to grandparents. Philosophically, for people involved in legal services for a long time, I think that there was never really, you kind of avoided like the plague representing grandparents against parents in cases with custody and situations. And that is a group that we have had to philosophically really say that we can't do that anymore. And that is a result of this, really the drug crisis that our communities are experiencing, because these are families that are really, like we said, in a situation that could be very destabilizing and that's dropped on them all of a sudden. And this is what the purpose of our project and what we try to do as an organization is, so we've had to broaden our representation to include grandparents, which was not an area that we would have normally been involved with. There's lots of lessons learned, and we always want to make sure that we can share any of those with you. And the slide may be missing from your slide deck that we have right there, but we'll make sure we get it added to the others. But it's definitely one of those learn from our lessons so you can avoid the same thing. And Brian, can you talk a little bit about some of those tips that you all have experienced as a team and what how you kind of addressed those?
Yeah. So basically, what we've taken a look at with this is in a basic sort of client that we get for the purposes of Kids Rise, what we generally do is there's an actual basic legal need that individual has. And in a lot of cases, that is probably not the most pressing need that individual has for the purposes of stabilizing that household. To give you an example, what we see in a lot of cases are relative caregivers, grandparents, who may have, for instance, sole custody of a child, but they'll want to seek an adoption, when in a lot of cases what would end up happening with that is that be very, very toughly contested, and then also that would be, it wouldn't necessarily provide any sort of practical benefit or financial benefit to the household. Now, we don't necessarily just refuse to do those wholesale if it will, for instance, if that's something that potentially the child would really, really desire. But what we find is that in a lot of cases, what we have to do is kind of get past that initial issue to sort of help the folks look at their overall situation. So what the very first thing that we'll do is we'll be very clear with folks if that initial concern is custody or adoption, what we're willing to do in order to assist with that issue and why we won't be doing those things. But then what we tend to do is we use an assessment tool to take a look at called the Arizona Self-Sufficiency Matrix that we use to take an overall look at the entirety of that individual's situation. So we'll take a look at, are there educational needs in the household that need to be addressed? Are there housing safety issues in the household that need to be addressed? So those are all things that we will take a look at there. So that's really the thing is that in many cases what we need to do is that first initial issue or their conceptualization of that legal issue that brings them in the door is not the primary thing or primary legal need that individual may have, and that's something that we need to take kind of a breather and take a step back and do an assessment of their legal needs in order to see exactly what the biggest need in that household is. One of the things that we've noticed, and I'm sure a lot of legal services organizations have noticed this as well, is that we have 4 different offices. So we have offices in the Lexington area, which is more of an urban area, the Covington area, which is a suburb of Cincinnati, more of an urban area, and then Moorhead and Ashland, which are more rural areas. We cover 33 counties. We have offices in 4. We tend to somewhat overrepresent individuals who are in those counties where our offices are. And we think a big reason for that is transportation. It's a lot easier for those folks to come on in. One of the things that this grant that we've received, I think, has challenged us to do is to more purposefully go out into the rural areas that we serve, because we're targeting essentially 7 counties that are the hardest hit in our area. We'll serve clients from anywhere, but we really want to focus on those to make ourselves present in those communities. And one of the things I think we've noticed is that sort of the biggest impact in terms of outreach and getting clients into our program, the biggest difference is in that outreach is that in urban areas, you can tend to do sort of those larger events. We had one for a group called Preventing Child Abuse Kentucky, where we made lots of great contacts with lots of great service providers. And so we kind of got a lot of bang for our buck in that. We met, hundreds of people in that setting, and we're able to really get the project out and publicized well in an urban area, in that urban area of Lexington. And then also we had one in Covington as well. In rural populations, it's a little bit different because you have to spend more time in those areas. You have to basically build connections. And one of the things I think we've kind of noticed is that in a lot of our more rural counties, Gallatin County, Elliott County, those counties are, what you need to do is sort of make a good connection with 1 or 2 sort of movers or shakers. And those individuals are not necessarily political. They're not necessarily in business. They may just be very well tuned into that community and the needs of that community. And once you sort of build a really good, consistent relationship with those individuals, everything else kind of falls into place. So, building those relationships are very important. Related to that,
when you build those new relationships, consistency is really key for those rural communities. So, so it's really important to not just go into that community, show up once, go to one meeting, say, hey, here we are, here's our project, here's how we can help. See you guys later, you know where to reach us. Going in month after month to the same meetings, to the same groups, really sitting down and listening to folks, that is so important in terms of sort of bringing in those clients from some of those rural areas. Because in a lot of cases, I mean, the communities that we serve, and especially in eastern Kentucky, are extremely rural. They're extremely poor. They're used to having folks coming in from the big city, basically tell them how it's going to be, essentially reaching out to them, appearing once. You know, they get their grant, they appear once, they're flash in the pan, and then, well, we'll never see you again. So what we've really made a point to do here is to really have a presence in those communities. And I guess the final thing that I think we've noticed
Brian,
up to yes.
If you could hold on that one before you do that final tip. I just said, as background, I will tell you that we really used data to identify the the 7 counties that we were focusing on under this project, and we created kind of a matrix to evaluate those from not just child poverty as an example. It was child poverty, chronic absenteeism, number of overdoses, number of families or kids that were in foster care, number of kids or percentage of the kids in the community that were in out-of-home placements or with a non-parent caregiver. We just created this matrix and plugged all of that in, and we identified 7 counties, as Brian was mentioning, several of which are closer to our more urban offices, and then it has a very larger rural component. In design of the plan, it may have been easier, as we kind of thought of it, to have made them geographically closer to one another. But unfortunately, none of the counties, I think, geographically touch one another. So it does require a lot of travel for the Kids Rise team. And like Brian says, that has been an obstacle as far as staying connected in the community, which is such an important thing. But kind of when we put the matrix and use the data to drive that decision, I'm not sure if I would have ended up with the same counties later had with that approach, but that was where it was definitely a need and somewhere that it pointed us. But I just wanted to share that that's we do have that and can share the matrix if anyone is interested in that, of what we use factors we use to identify those counties. Thanks, Brian.
Sure. Yeah, and that's a great point. We used a lot of data basically to take a look at things like school truancy rates, out-of-home placements, things like that, the number of overdoses in those counties, in order to kind of build those focus areas that we really wanted to focus on for the purposes of the grant. One of the things I think that has been probably most interesting coming out of this too is I think, you know, working in legal services as well, and I've worked in legal services now for 12 years, we kind of have a set group of cases that, you know, we as a practice kind of look at. We have, you know, sort of our family law issues, our housing issues, we have public benefits issues, we have, you know, wills, powers of attorneys, and things like that. And I think there is a tendency, because we are, as legal services attorneys, experts in those areas, to kind of stick to what we know. But one of the things I think that has been probably most interesting coming out of this is that there are sort of new areas of practice that I think we've seen arise that we're taking a look at right now, and sort of thinking creatively about how we can assist individuals with these things. So one of the first ones that kind of came up is that we were talking with some individuals at a recovery center in one of our rural counties, and the individual there essentially had done a whole lot of work to essentially turn their life around. So they had been drug and alcohol free for a period of 2 years. They had served for a while as a peer mentor, and then also they had been hired on by this recovery center as a drug and alcohol abuse counselor, sort of informally, to some of the other individuals in recovery there. One of the things is that individual wanted to go back to college, to Morehead State University here, but due to their record, their criminal record and some of the things that showed up, they were unable to get into the program. And this individual had done everything that they needed at that point in order to get past their addiction, but they still couldn't have the tools that they needed to complete their recovery, which in this case was to essentially go back to college, get their degree, become a certified drug and alcohol counselor, to get a degree in social work. And so what we're able to do is look at the administrative process and how do we challenge that determination by that university on an administrative basis. So that's one of the things I think that was sort of a new practice area that I think we're going to think a little bit more creatively about in terms of helping folks after they get out of recovery. Another thing that we've seen is that, like I kind of referenced earlier, there are a whole lot of cases where drug and alcohol abusing parents tend to just dump a child on a grandparent or aunt or uncle's doorstep. In a lot of those cases, there's not necessarily a formal finding of custody, but once that child hits 18, then mom and dad are in the wind, and that grandparent doesn't necessarily have any legal claim to custody established yet. So if that child wants to go and qualify for federal student aid, they need assistance with a student dependency override, okay? And so that is something that we haven't necessarily done too much in the past, but I think that's something that we really also want to think creatively about using for some of the kids that we're helping in the program, just because, they essentially have had such a hard time probably in life, been undoubtedly exposed to a fair amount of trauma, and they are willing to and want to take that next step towards independence, and they're unable to do that because there's essentially no parent there to assist them with that FAFSA and also to enter their information into that as well. So those are essentially two areas I think we've seen that have kind of jumped out at us while we've started doing this work. So I think that's a really interesting thing about serving this population is just, there are new things and new areas I think for us to go into in order to really provide the most help that we can. So.
Thank you all for listening to us about Kids Rise. We have the slides that the one that was missing, so we'll make available or get that to Casey. And we're happy to answer any questions. Our contact information is below, and you can learn more on our website about the Kids Rise project. And we'll be sticking around for some of the Q&A. But thank you all for listening, and please let us know how we can be of help.
Great. Thank you so much, Joshua and Brian. So we are, this might have been the slide. So we are going to move on now and hear from James. I'm going to give you presenter privileges, James.
Okay. Can everyone hear me, first of all, I guess?
Yes, we can hear you, Joshua.
Okay. All right, great. Well, thank you. As stated, my name is James Connelly. I'm the Executive Director of Washoe Legal Services. And what I am going to focus on is our medical legal partnership that has been up and running for about 2.5 years. So I'm just briefly going to talk about what is a medical legal partnership. I'm sure most of you have some idea already, so I won't spend too much time on that. The background of our medical legal partnership, which is with an organization called Northern Nevada Hopes here in Northern Nevada. And then I'll talk about how MLPs can address some of the legal issues that that we see in our substance use disorder patient and client populations. So first, what is a medical legal partnership? The definition, I put the definition of that is on the National Center for Medical Legal Partnership website on there, but I sort of reduced that down into my own little definition, which is, medical legal partnerships improve social conditions in order to improve health outcomes, which in turn reduces the overall healthcare costs for the patient at issue. And there are currently, again, this is all on the Medical Legal Partnership website, there are currently 333 MLPs in 46 states. And I put links to, for more information. I'm not going to click on them here in this presentation, but that's the link for the Medical Legal Partnership National website or national organization, and a brief video that PBS did on medical legal partnerships, I don't know, probably 3 or 4 years ago. So if you're ever thinking about creating a medical legal partnership and you're making a pitch to funders or your board or something like that, that little video is a great way to show the effectiveness and the sort of the philosophy behind medical legal partnerships. So I wanted to give you a little bit of background about Washoe Legal Services. Because I think it's often difficult to talk about a specific program within an organization without having some context around the whole, the whole organization itself. So we are a legal aid organization here in Washoe County, Nevada, which is where Reno is located, in case you don't know. So that's the northern part of the state. A little bit of background on the demographics of Nevada. Where there's about 3 million individuals in Nevada, and 2.5 million of them are live are concentrated in the 2 urban areas, Las Vegas, which is Clark County, Nevada, and about 500,000 people live in Washoe County, and the other 500,000 in Nevada are spread out across a huge rural geographic area. So our office, most of our clients are in Washoe County, but we do serve some individuals in the surrounding rural jurisdictions, and we serve about 9,000 individuals per year in various different programs. I have them all listed there, and the reason why I list all of our different programs is because you can see a healthcare component to almost all of those areas of law, whether it's child advocacy, where we are, court-appointed counsel in dependency and neglect cases appointed to represent the child. In Nevada, children are entitled to independent legal representation by statute, and we are the agency that provides that service in Washoe County and some of the other surrounding counties. Similarly, adults who are under guardianship are also entitled to independent legal representation under Nevada law, and we represent protected adults in those proceedings. And then we have a victim advocacy department, which focuses on victims of domestic violence, human trafficking, sexual assault, et cetera, and the various other programs. I won't go into detail on those. But, almost all of those programs have some healthcare component to them. So even though our medical legal partnership focuses on patients with healthcare issues, in reality, most of our programs have that component in some shape or form. And we have an annual budget of about $3.2 million. We don't receive any LSC funding. All of that goes to a separate legal aid organization, so we can avoid the restrictions placed on that funding. And I listed our primary funding sources down there, and I bolded the Bank of America foreclosure settlement funds that went out to various IOLTA organizations throughout the country, because that is the funding source that we use to start our medical legal partnership. And then our MLP partner, Northern Nevada Hopes. They started, again, they're headquartered here in Reno. They're just probably 6-7 blocks away from our main office. They were founded in 1997 with a focus on providing advocacy and outreach and healthcare services to the HIV-positive population, but they have since grown into a more comprehensive healthcare center. You can see I listed most of the services that they provide. You know, they now do primary care, pediatrics, they have an on-site pharmacy, they do behavioral health. They offer case management services for patients who need it, and they take a real team-based, patient-centered approach to healthcare. You know, it's a very holistic service that they offer to our community. And I broke down the types of patients that have visited there in 2018. As you can see, more than half of their patients are below the 200% of the federal poverty levels. Almost 20% of them have experienced homelessness. Almost 800 HIV patients, almost 4,000 receiving case management services. And over 2,000 patients are in substance use disorder counseling. And one other interesting statistic they exchanged over 1 million needles in 2018 alone. They employ a harm reduction model to substance use disorders, so the needle exchange is an important part of that model. And the reason why I want to break down or take some time to talk specifically about Northern Nevada Hopes, their values, their focus, their philosophy to treatment, is because if you are interested in starting a medical legal partnership, that's what you want to look for. Who your partner is in the healthcare setting is going to go a long way in the success, or is going to be an important factor in the success of your medical legal partnership. So you really want to look for a healthcare agency that has a focus on a very vulnerable patient population, which you can see Northern Nevada Hopes has that. And number two, takes a very holistic approach to healthcare, that they have social workers on site and case managers on site to assist, who are actively assisting their patients with health-harming social conditions. Because one of the more successful components of a medical legal partnership is having a very close working relationship with case managers and social workers, because essentially they're on the front lines trying to address any health-harming social conditions that their patients have, but eventually, on many cases, they hit roadblocks, and many of those roadblocks are legal impediments to housing, health care, not just impediments to housing, but impediments to safe housing. And whenever the case managers hit a roadblock, that's whenever they were going to make a referral over to our medical legal partnership team. And the timeline of our medical legal partnership, we started, I became the executive director of Washoe Legal Services in 2016, and shortly thereafter, Northern Nevada Hopes reached out to us, indicating an interest in starting a medical legal partnership. And just as luck would have it, just probably a couple months after our initial conversation, that's whenever our local or our statewide IOLTA facilitator, the Nevada Bar Foundation, announced the funding opportunity from the Bank of America Settlement Funds. So that, for those of you who don't know, that particular settlement was limited to assisting clients with foreclosure issues, or creating community programs that focused on community development. And because the MLP is essentially a public health initiative, we couched it as community development, and we were awarded a 3-year grant basically to start this as a pilot program, and we awarded that in 2017. It obviously takes a little while to staff up, so we hired our first two and only staff members in the program in April and May of 2017. It was a $155,000 annual grant by way of context, so funded 2 full-time positions. One was a Washoe Legal Services attorney, so that's a staff attorney position here. They are a staff member of Washoe Legal Services, but her office is at Northern Nevada Hopes. And Northern Nevada Hopes is a sub-grantee of ours under the program, and they separately hired a program coordinator who is a Hopes staff member, not a Washoe Legal Services staff member, but they work together in the same office. The referrals go to the program coordinator. She sort of triages things, sets up appointments for the attorney, and they work just hand in hand with the entire care team over at Northern Nevada Hopes. So it's our medical legal partnership, and technically all true medical legal partnerships are much more than just a referral relationship between a healthcare provider. Our MLP attorney is actually on site 5 days a week, unless she's on vacation or something, and of course the Hopes program coordinator is on site. They receive direct referrals through the electronic medical records, and can of course make notes in the patient's electronic medical records. Our attorney has access to those, as does the medical records, as does the program coordinator, so they can communicate to other members of the care team through that system. And like I said, the MLP staff are part of a whole multidisciplinary team that's delivering care to the patient. And one other aspect, again, going back to the various different programs that we offer, our MLP attorney, she does not necessarily handle every case that is referred. Of course, some are rejected because it's outside of our area of expertise or just not something we focus on. But in addition to rejecting inappropriate cases, she will often not open the case herself, but start a referral to another program area that may be better suited, whether it's someone who's experienced domestic violence. She may may refer them to our victim advocacy unit. If it's a senior, they may be referred to our senior unit. But having that staff member on site really streamlines the referral process and streamlines the application process for the client. And so our service members to date, like I said, we've been up and running for approximately 2.5 years. In that time, that's resulted in just under, well, actually it's over now because this data's not up to date, but right around 370 total cases that our MLP attorney has handled. Now that does not include cases that may have been referred to some of our other programs. They've actually received a total of, I believe, 580 referrals to the program. So some of those clients were either rejected as it was an inappropriate case, or they may have just been referred to another Washoe Legal Services program. Like if it was someone who just wanted to get a custody order and there's no really complicated issues, they may be referred to Washoe Legal Services self-help program, but they would not be tracked as a medical legal partnership client. So those cases solely reflect the clients who were served under that program and under that particular funding source. And as far as the types of cases we focused on, I broke those down as well. Over 100 housing cases, that's a focus of our program, and 90 family law cases, and 30 immigration cases. Our original MLP attorney had an immigration background, and we had several other immigration staff members with immigration experience at the time, so we were able to handle a lot of immigration matters through the program, but staffing needs changed as the program went along, and we don't handle as many immigration cases as we had previously. And the key concept in looking at these cases and the different areas we focused on, and just the volume of cases, is that none of these clients came to Washoe Legal Services asking for assistance. They were being treated at Northern Nevada HOPES, and a HOPE staff member identified a legal issue because that's part of their holistic patient services and screening for these types of issues, referring social issues to case management, and when they hit a roadblock, referring the client to us. And that's one of my favorite parts of a medical legal partnership. I often think that the clients who need the help the most are the least likely to see it, or least likely to seek it, or the least likely to know about it. And having a partner who takes a holistic, whole person approach to healthcare will help you identify those very vulnerable clients. And this is just a chart with that same data. In addition to the direct client services provided, we've also offer frequent legal education clinics to both the staff at Northern Nevada HOPES to help them understand and appreciate legal issues that may be impacting their patients. And we offer legal education classes and clinics to the patients at Northern Nevada HOPES. And those service numbers, the 405 clinic attendees, that's not included in the 370 cases that I mentioned before. So for just a essentially a two-person operation, they have been incredibly productive, in my opinion. And of course, when I say cases, though, not all of those cases are, obviously direct representation in litigation. It's really a spectrum of services. Some of them are, brief services, advice and counsel, but a great deal of them are direct representation in either negotiation or litigation. But they really run the spectrum. And a few case studies. I tried to select some cases that had a strong connection to both the legal issue and the healthcare issue, and also cases that where we're more involved rather than brief advice and counsel, and of course cases that either involve substance use disorders or general mental health treatment. And just one point on that before I go further, if you're thinking about starting a medical legal partnership, and you'll see this on the National Center for Medical Legal Partnerships website, you can obviously make it as broad or as limited as you want. We made ours very broad because we wanted to capture a broad patient base, and it was a pilot program. We were trying to get a sense of the type of cases and the type of patients that would give us the most bang for our buck. But many MLPs, they either are limited to a certain demographic, whether that's children or seniors, or limited to a certain diagnosis, such as asthma, substance use disorders, other chronic health conditions like diabetes that have overutilizers of healthcare services, or you can limit it to a particular legal service, housing, or Medicaid issues, elder exploitation. There's really no limits other than your imagination. We made ours very broad as we will probably make it more restrictive in the future, but we wanted to get a sense of the need that was out there and the type of cases that were out there before we dialed back the restrictions. So just a few brief case studies. The first one I put in there, we had a grandmother whose grandchild was a patient at Hope's. This, as this was a victim of the opioid epidemic. Her biological mom was actively using heroin. Her whereabouts were unknown. Grandmother is caring for the child, but had no legal authority to make healthcare decisions for the child. So we petitioned for minor guardianship over the child. The biological father could not care for him either because he was living in a weekly motel and had very unstable housing. We filed the original guardianship petition, but as with many of our cases, we'll often get it started while we're trying to place the case with a pro bono attorney. And we were fortunate in this case, a pro bono attorney agreed to substitute in, and he finished the case for us. Just as a side note on that case, I was reviewing the docket just the other day, and the father now has much more stable housing, and they're petitioning to terminate the guardianship now. This case is about 3 years old. They're petitioning to terminate the guardianship because the biological father is now able to care for the child. So it's one of those cases that have a happy ending. At least looks like it's going to have a happy ending. Another patient who we'll refer to as Dave. All these patients' names have been changed, obviously. He was HIV positive. He's chronically homeless with schizophrenia. Case management applied for public housing for him. It was denied because of a criminal conviction. They couched his criminal conviction as a violent felony. It was actually a fairly minor battery conviction that was very old. So the medical legal partnership attorney challenged that determination from the housing authority, and found him in. She successfully appealed the denial, and he was able to obtain his voucher. And finally, Rachel. She was a Hope's patient also with a substance use diagnosis, and she was in active recovery, in treatment. She was the victim of stalking. She was calling the police office, the law enforcement to her rental unit in order to, due to the perpetrator of the stalking showing up at her house. They tried to evict her for a nuisance, for contact with law enforcement, and we successfully defended that eviction for her. And as far as lessons learned thus far through the program, and any tips that we may have for you if you're thinking about starting one, if you're going to focus on a particular legal issue in your medical legal partnership, then housing is the most obvious one to focus on. When you're dealing with a very vulnerable patient population and client population, housing will homelessness will exacerbate almost every chronic healthcare condition that there is. We don't know it for sure, but anecdotally, you can just imagine if you were in treatment for any type of substance use disorder, losing your housing could be the triggering event that causes a relapse. Just the stress associated with that, and any external stressor like that is going to could possibly be a triggering occurrence for a relapse. What is particularly challenging, though, in theory, we can say that legal interventions create better healthcare outcomes. But what's lacking pretty much in all of the medical legal partnership data is really good evidence of that. I think anecdotally we can show it case by case, but it's extremely challenging to try to prove that with any sort of with any real confidence. We tried selecting a bunch of different criteria to track within the patient and client population that we've had through the program. Things like tracking ER visits and hospitalizations to show healthcare savings, or tracking no-show rates for appointments, or just tracking whether or not individuals with substance use diagnoses are more likely to stay engaged in treatment. But we just found it incredibly challenging to do that. It's very staff intensive. It requires a lot of follow-up with your patients, and when you're dealing with a transient, vulnerable population, follow-up is very difficult. You know, they don't have the same phone number for long. They don't have the same address for long. And even if you do get good data from your patient population, you're able to follow up with them and track hospitalizations or relapses or something of that nature. What group do you compare it with? Because most people who are referred to the medical legal partnership are the most vulnerable of all of the patients within the healthcare organization. So it's not, you don't really get an apples to apples comparison whenever you're comparing that population against the rest of the patient population who is relatively stable. But like I said, anecdotally, I certainly believe that they work. I certainly believe on a case-by-case basis we can show a good impact to that we can show good health outcomes on a patient-by-patient basis, but it's very difficult to prove an overall trend. And again, just to stress the importance of identifying a good MLP partner. If you find an MLP partner that has a person-centered and integrative approach to healthcare, they are going to be a great natural fit for an MLP. And that's all I have for you, but of course I will be happy to entertain any questions that you have. I have my contact information there if you want either a copy of the presentation or any follow-up questions regarding our program. We would be happy to I'd be happy to provide that to you, but thank you.
Great, thank you. So we do have a few questions that have come in. As more start to trickle in, I'm going to go ahead and ask the first one. So this first one goes to Legal Aid of the Bluegrass. Can you speak more about the continued presence in those rural communities, given a lack of a storefront field office? What specifically were components of that?
Sure, and I'll let Brian speak about a couple of examples, but I want to share one, which is our mobile office, our Justice Bus. Interestingly, several of our counties that are part of our Kids Rise project also are offices that we were targeting as being underserved by us as an organization. And we have a mobile office, which is a Justice Bus, which is a converted Sprinter van that we can take into communities in all of these events. There's an MIE Journal article about the Justice Bus. There's also an LSC's website about and best practices, which would show you some pictures. But it's a very it's meant to draw attention when it comes to town, and you notice it. So part of our presence in an intentional way is our Justice Bus. So even though we don't have a bricks and mortar office that way, we have our Justice Buses often at events. And even if it's not a Kids Rise specific event, we use the technology on the Justice Bus to connect with the Kids Rise team. And so we may be there for a senior event, but somebody asks questions that end up, from a grandparent who happens to be there about their health insurance, who asks us some questions, and we learn something else. We're easy to tie them in with the Kids Rise team and use the Justice Bus for them to connect and meet. Brian, what other things?
Yeah, so I think one of the big things that we have done in order to build sort of a continued presence is kind of like I was talking about, I think, a little bit earlier, is just making those connections with one or two people and just being consistent in those. So to give you a very specific example, one of the first counties that we went out to was Gallatin County, which is a very rural county along the Ohio River. In that, the very first thing we went to was a grandparents acting as parent support group. There was a school resource officer who was there, who we sort of hit it off with and befriended at that meeting. The meeting was relatively small. It was maybe 8-10 people. We brought sort of a laptop in order to do intakes if anybody was interested in potentially seeing if they were eligible for services there. But also we kind of tried our best to build relationships with the folks in that community. And since that time, that resource officer has invited us to interagency council meetings, what they call the Champions Against Drug meetings, which are essentially the anti-drug abuse coalition in the county. They've invited us to back-to-school events, basically, and resource fairs. And they've done just an amazing job of just introducing us as service providers to other stakeholders in that community. So that has been something I think that's been extremely valuable. And out of the maybe 4 to 5 rural counties that we're really trying to focus on with our grant, probably 3 or 4 of those counties, we have that 1 or 2 really strong connections, which have really helped us sort of get those referrals from those counties. Another thing that and it's somewhat related, that I think we're trying to do now, and we're reaching out to the school resource officers. School resource officer, I'm not sure if every state has those. They're kind of like a counselor on steroids. They not only sort of listen to the child's problems and provide, educational counseling, things like that, but they also sort of connect them with different resources in the community. So one of the things we're doing is we're reaching out to the school resource officers in those counties in order to set up in-school clinics. So we don't need really a whole lot of assistance in terms of setting those things up. We really can just show up 2 lawyers or a lawyer and a social worker with a laptop, as long as they have a little bit of space for us to come for 2 to 3 hours. And really what we just need to do is make that initial client contact. We don't have to, sit down and have that sort of extended case consultation, as long as we can get their information, screen them for eligibility, screen them for participation in our program, and then at that point we can handle a whole lot remotely if we need to do that. So those are, I think, really 2 of the things that we've tried to do to really sort of break into some of our more rural communities.
Great, thank you. So I have a question for James. What percentage of all cases coming through your regular legal services door, so not just the MLP, end up being opioid related or drug related, any or all?
I don't think I can answer that, because it's not something we typically track. At any given time, we're representing around 1,000 children in the foster care system, and just extrapolate. And they're probably the majority of those cases involve some sort of substance use disorder, but it's not something that we independently track. The same thing with our domestic violence cases. Obviously, a lot of those cases have a substance abuse component to them, either on the part of the client or the perpetrator, or oftentimes both. But it's not something that we independently track, so I can't give you a good number.
And then this is a question for all of you. Have you found an issue with conflict of interest? For example, having represented a mom in a DV protective order and then getting a request for help on custody from grandparents. In our rural areas, there is not a lot of options if there's a conflict. What do you do?
I'm sorry, what was the question? Do we get a lot of issues with conflicts of interest?
Or how do you handle conflicts of interest.
Okay. So I guess first, I mean, I always take the approach that, legal aid organizations don't have have the luxury of taking an expansive view of the conflict or an expansive interpretation of conflict of interest rules. So we try to, when at all possible, really devote, sufficient just because something pops up as a potential conflict, we don't turn that client away. We'll talk to the attorney who was originally on the case to see if it's a real conflict or just an actual conflict. By way of example, we, on our child advocacy cases, we list the parents as adverse parties, but they're really not adverse parties in a lot of the cases. A lot of times the interest of the child and the interest of the parent is aligned. So if that, if the permanency plan in that case is reunification with the parent, and we are advocating for reunification with the parent, and that parent comes to us with a landlord-tenant issue, we are not going, and I believe this is completely consistent with the conflict of interest rules, we are not going to turn that individual away for that level of service because there is no conflict of interest in the actual positions of the clients, even though they are technically listed as an adverse party in the proceeding. So that's one way we get around it, is by taking a more restrictive view than what a law firm, private law firm may take in those cases. But at the end of the day, we do have to occasionally turn away clients on the basis of conflict of interest. And when we do have to turn them away, like I said, we are not an LSC grantee. The LSC grantee in our state is Nevada Legal Services, so we can make a referral over to them, possibly, or we use our pro bono program primarily to represent individuals that we are conflicted off on.
Yes, I think I would agree with that as well. I mean, we always definitely look at, consistent with the conflict of interest rules, what specifically that parent, or that prospective client would like interest or would like assistance with. And so in doing so, if there's a housing issue, while we may have represented somebody else in a custody issue, that may not be a really huge issue in terms of conflict of interest rules. But I know, and one of the things is that we've recently had sort of a symposium with the other, we are LSC funded, with the other 3 LSC organizations that received the grant under which we're doing the opioid interventions. And it did come up, especially in West Virginia, where they're sort of doing some of the school-based outreach, that they are having an issue with multiple conflicts of interest. We do have a few other organizations that we might be able to refer clients to, but really we have not come up on that a whole lot outside of a few cases when we've been able to kind of scoot around those. But I definitely see how that can be challenging, especially when, in a lot of cases, when you'll have a parent and a grandparent and they're both interested in custody or visitation issues. Of course, that's, that their interests are incompatible under the conflicts rules. So, yeah, I would agree that it's an issue, especially in rural communities. But we try to make referrals when possible and then get around those when we can.
Thank you both. And
also, and of course, another possibility, sometimes you can get a waiver from the client, again, depending on the conflict, but we always encourage someone to try to get a waiver. And for instance, if a parent is if we previously represented a parent on a housing matter, and now that parent is involved in a dependency and neglect case represented by the Public Defender's Office, and we're appointed to represent the child, we will, even though it may not be an actual conflict, we will try to ask the public defender if their client is willing to waive the conflict and allow us to represent their child. So that's another way we try to get around it on occasion.
Great, thank you both. So we have a few questions on MLPs. So the first is, we have an MLP with a provider that works with opioid users. We're finding this population very difficult to work with, many calling us, asking us for money, and not usually thinking about legal issues. We've done trainings for staff. Do you have any guidance on this?
Yeah, that was always a work in progress. It's one of the benefits of having individuals on staff working hand in hand with sort of the case management team, because early on in the process, we would get a lot of referrals that were inappropriate because it wasn't really a legal issue, it was a financial issue. You know, someone can't find housing because they don't have money, not because their landlord is doing anything illegal or their legal rights are being impacted. They just may not have the assets to obtain housing. So it was really working closely with the case managers, and this again goes back to the importance of identifying a good partner so that you can have that back and forth, and you can do some training on when something becomes a legal issue versus just a broader financial or social issue. But I don't have any great tips other than making sure you have a good, open, collaborative relationship with your MLP partner, and you can sort of work through those issues as the program matures.
We have another question about building partnerships with MLP. What is the best way or some tips you have to initiate a conversation or meeting with a community health center to assess if they are the best fit for an MLP?
Well, I would, we were fortunate enough where they reached out to us. Like I said, I had just become the executive director of Washoe Legal Services when they did, and I didn't even know what an MLP was. So they were educating me because their director of operations had gone to an MLP conference, and she was really interested in starting one, and she reached out to us. But it's basically what I've already stated. You know, my main piece of advice is first of all, look for a provider that has a whole person focus, that focuses on, a very vulnerable population and that believes in whole person care. You know, do they have on-site case managers? What percentage of their patients receive case management services? What type of case management services do they offer? And if you find someone who has social workers on site, case managers on site, I think they will understand the importance of getting an attorney involved because they will have instances where their case managers hit roadblocks due to legal barriers. But I suppose to address your question more directly, as far as starting a conversation, first of all, identify a good partner who has those attributes, and I would be surprised if they hadn't already heard of a medical legal partnership and have some understanding and some interest in it already.
Thank you. So this is a question for Legal Aid of the Bluegrass. You mentioned a nationwide rate of children raised by non-biological parents. Do you have any tips on how to find local or state rates, and what was the source of this data?
Yeah, so that was something that when we decided to target what we call sort of our 7 hardest hit counties in our service area, we used a lot of data from the Annie E. Casey Foundation. Their kids count data was very valuable to us because it provided just a whole ream of sort of intersectional data that we could use about the counties in our area. They're a really great resource, and I'm fairly certain that they produce a large amount of data on every single state, not only nationally, but every single state. And at least in the Kentucky case, they were able to break it down in terms of county. So we were really fortunate in being able to use that to get a really good snapshot of what was going on in our individual counties. And so at that point, we sort of, I think we nearly pretty much picked the metrics out of there because their data was so good that we were able to really focus in on those 7 counties. And so we looked at, drug abuse rates, and it had just so much data about children's well-being as well. And so that was a really valuable source for us, and probably the primary source, I think, that we relied on in doing that.
So we have one follow-up point, not really a question. So on the question for best practices, someone wrote in and said, I would recommend trying to look up the health center's mission statement, as this will really let you know what they are all about. We definitely agree, and thank you for sending in that tip. And then we have just one more question. So if there's any questions that are still burning and that you want us to ask and hear our panelists answer, please send those in now. So the last question is, have you experienced any difficulties regarding intake? For example, a client referred by a medical team but not eligible for legal services. So these are issues unrelated to conflict of interest, and how do you go about dealing with those?
If I could clarify the question, I thought it was, did you say issues with Medicaid? Is that?
No, so if a client is referred by the medical team, but they're not eligible for legal services, what do you do then?
Oh, yeah, I mean, we would handle that, and again, like I said, we had over 500, close to 590 referrals to the program that resulted in 370 cases. So that does come up a good bit, and we just handle that like we do with any other type of individual who comes into our office who we cannot serve. So, we don't do personal injury or medical malpractice cases, yet, especially early on in the program, sometimes those types of issues would be referred over. And also, I always encourage people to make referrals. I don't like them to screen our clients for us. And I say that because a lot of times people think they're making a referral for one legal issue, and you don't let the client define what the legal issue is, and you don't let the medical provider define what the legal issue is. So I don't like clients and partners to do that screening. I would rather us do it. So, a client may think that they need, for instance, to file for bankruptcy, and we don't do that in our office. But I still like people with bankruptcy issues to be referred over because it may not be a bankruptcy issue. It could be a Fair Debt Collection Practices Act issue. They may be judgment proof or whatever. I still like to receive the referrals. So, but at any rate, I think the providers are understanding of that. If they refer something over and we cannot help them, we will still refer them out, So let's say it's a personal injury issue, we would refer them to the lawyer referral service, because most of those cases, if it's a good case, will be taken on a contingency fee. So if it's a case with merit, they should be able to find legal counsel through the lawyer referral, statewide lawyer referral service. But our MLP partners understanding of that we cannot. We don't have the bandwidth to take every issue that comes down the block. And again, that's just part of the back and forth in working with your partner.
So thank you both, James and Brian, for answering the really great questions from the audience. So before we completely wrap up, I have one additional slide. So this is to put in another plug for the Just Research newsletter. The Just Research newsletter is, as I mentioned before, sends curated research to you every month. The upcoming theme will be foster care. We are going to be highlighting a recent policy change in Title 4E, which allows states to claim federal reimbursement for parent and child representation in child welfare cases. for those who are 4E eligible. And if you liked this webinar, the series, or like NLADA, the Justice in Government Project, or Karen Lash in general, please fill out our survey to help us better meet your needs. This is both to report to our own funders as well as tell us what you're looking for. For example, something that has come up in the survey and conversations is a shared Dropbox or folders with successful grant applications, MOUs, and best practices, and we're making that happen. So we really do listen to your feedback, so please send it on in. With that, I want to extend another big thank you to all of our panelists, Joshua, James, and Brian. Thank you so much for spending your Thursday afternoon with us, and to all of the audience members for their participation, questions, and for doing the great work that you all are doing. With that, I'm going to end the webinar. I hope you all have a great rest of your Thursday.
Thank you.
Thank you. But it's only Thursday morning here, so I still got my Thursday afternoon to myself. Take care.
All right, you too. Bye.